in some populations, the medical research tells us that these patients clearly don't want life support. They don't want their lives sustained by machines, by mechanical means, and they don't want to die an institutionalized, mechanized death. My master's thesis was in this area, and one of my mentors there, Darren Hyland, has spent his career doing research about end-of-life care. And decisions at the end of life. And what we know is that a lot of elderly patients would prefer to die at home in the presence of their friends and family, and they don't want an institutionalized death. And yet, probably because of just flaws in the system and maybe a lack of excellent communication surrounding end-of-life goals, a lot of these elderly patients end up exactly where they didn't want to be. Where our research tells us they don't want to die, which is in our ICUs on life support on machines. And we know this because a lot of them end up there, and then within a day or two, family finally comes to us and after really seeing what's going on with their loved one and says, you know what, this isn't what they would want. We need to let them die and keep them comfortable. But sometimes it can take a number of days for this to happen. And so I think the most important thing is that this isn't what the patients wanted. We're disrespecting their autonomy, their values. But secondary important effects are that we're tying up hospital beds and spending a lot of money, and then other critically ill patients don't have the same access to those beds. So again, the emphasis is on the patient preferences and what they want, but there's these other downstream negative effects as well.